Okay. So just to give you a bit of background and to be on the same page in terms of what we mean by public health and social measures, because the framing has evolved through the recent pandemic. So PHSM are non-pharmaceutical interventions that are implemented at various levels, at community level, individual level, but also at regional and global levels. And they're implemented by individual institutions and government. And the primary purpose of PHSM is to reduce the risk and scale of infectious disease transmission. So we're talking about reducing transmission rather than exposure, and or making them safer. While this PHSM initiative was born out of the COVID-19 pandemic, we have an expanded length of looking at human to human, animal to human, vector to human, direct contact related mode of transmission. So we have a multi-hazard approach and how we frame PHSM. And we really see this as a life-saving intervention. And some of the things that I really want to highlight is the key strength of the PHSM. They are often the first and only, sometimes the only interventions that decision makers can rely on, especially when medical countermeasures such as vaccines and therapeutics are not available at the onset of an outbreak. Or that they are not effective or equitably distributed, we really need to rely on public health and social measures. We have highlighted that the community engagement is extremely important because that's where health emergencies begin and end, and that's where the contextual factors really impact the effectiveness of PHSM, but also the uptake and adherence to PHSM. So PHSM cannot be considered in vacuum, really need to be considered in terms of medical countermeasures, but also RCCE and infodemic management of enabling functions. I want to play a video. I really hope that you can hear the audio through Zoom. Let me know if you can hear it.
No, we can't, Ryoko.
Such as hand washing.
Can you hear now?
Ventilation.
Yes.
These measures were in.
Ryoko, we can't hear.
But school closures impacted children's learning and development, and for some, even resulted in loneliness and hunger. More robust evidence is needed to better understand which, when, and for whom these measures work. We also need a clear picture of the health, social, and economic impacts they have on our communities. This research is essential for leaders to make decisions based on evidence that will both maximize the benefits on health and minimize unintended negative consequences for communities. The World Health Organization is calling for greater collaboration across sectors through the Public Health and Social Measures Initiative, because the more we understand now, the better prepared governments and communities can be for our future.
So when we speak about public health and social measures, we're talking about a very wide range of measures. Some of them classic traditional public health measures. So from the left, you're familiar with active case finding and contact identification measures. Personal protection measures, those are classic IPC. And also environmental measures, including WASH, vector control, and also ventilation, air quality measures, and animal-human interface-related measures. Social measures were quite prominent during COVID-19. And this ranged from measures that address social interaction, so physical distancing, restrictions in terms of mass gathering, domestic mobility is another measure related to stay-home order, restrictions related to public transport, and certain areas of the countries or regions. And lastly, modifications to activities such as school opening, business opening, and there's a range, right? So the extreme version might be closure of schools and businesses, but also they have modifications to activities. So for example, canceling classroom activities, PE, for example, if there's not enough indoor spacing, if it creates more crowding, implementing some distance and online learning, and modifying the service hours and such. And the last one's international travel and trade measure. So today we're talking about this type of range of measures that have been implemented. PHSM benefits, the public health benefits, are that they reduce the number of cases, infections, and consequently reducing the pressure on the healthcare system, and also buying time for medical countermeasure development and distribution, and trying to keep school and learning open and safe. On the flip side, however, we have witnessed and learned about the significant and sometimes severe unintended negative consequences of PHSM implementation. So we're talking about not just the impact of health emergency itself, but also the impact of PHSM implementation on individual health systems, economy, society, and human rights. Some of these examples include domestic violence, food insecurity, loss of income, slowed productivity, trade activities, and such. So the decision makers really try to grapple with the balance and the trade-off between the public health benefits of PHSM and unintended negative consequences of the implementation. So some of the questions that they have been asking is, what can we do when vaccines and therapeutics are not yet available? What do we know about the effectiveness of PHSM? Is there guidance on risk-based evidence-informed decision-making for PHSM? How do we balance these benefits and negative consequences? And what can governments, partners, and communities do to mitigate these unintended negative consequences? So there have been a lot of these questions and also asks to WHO to address these. So PHSM policy and implementation sort of looked like this. It's very complex pathways. It's not just a linear, clean direction of how interventions lead to outcomes, but there are quite a bit of effect modifiers, culture, politics, adherence, public trust, resources, feasibility. All of these factors are involved in how PHSM interventions become effective and actually bring the desired public health outcomes. So some of the context and challenges that we have come to realize now is that the current evidence base on PHSM effectiveness and impact is quite low to very low certainty, so meaning the quality is really limited to be able to make definitive or directional statements about PHSM. Timely and relevant research and data to effectively inform PHSM decision-making has been scarce. And we really need good data, good research during emergencies on the effectiveness, these unintended negative consequences, the level of adherence and uptake among communities, and also what would be the good practice and implementation strategies to ensure high adherence and uptake, but also strategies to reach the vulnerable and underserved communities. In terms of policy making and implementation, we learned that risk assessments are not always conducted robustly or in a timely manner, and the identification of control measures based on risk is still limited. So we really need to think about how we best identify control measures such as PHSM that are proportionate and relevant to risk. Even when you identify effective PHSM that are appropriate to risk, the effectiveness and the success of PHSM really depend on contextual factors. So it really needs to be adjusted to evolving contextual factors. And for that reason, community engagement has been the key theme, and hence PHSM is launched under community protection and HEPR. So we really need to have a mechanism in place and guidance in place, particularly for PHSM decision-making, monitoring, and decision-making, and research conduct. And this is the area that we'd like to brainstorm with you, and how we best get the real-time data and insights on how communities are impacted by both health emergencies, but also PHSM implementation. So what we have, what we would like to focus on in terms of community is this, and I think this is what your network resonates with, because this is primarily the focus of IOA. We need community sourced data in terms of feasibility of PHSM and also adoption of PHSM, the negative impact or negative consequences that they're experiencing due to PHSM. What can health and non-health sectors do to mitigate or reduce the negative consequences of PHSM? How best to really look at these, not just epidemiological factors, but also behavioral and cultural insights into decision-making. For decision makers, their interest is really to maximize public health benefits while keeping these negative consequences to minimum, but also to ensure that whatever decision they make is equitable, context-specific, and balanced. And that is not just the job of the health sector, but also non-health sectors. Because most of the PHSM are implemented by non-health sectors. We're talking about education, finance, trade, travel, and such. So we really require multi-sectoral coordination for PHSM at all levels. Another aspect is the precautionary principle. And we use this term quite often without having clear mechanisms or systems or criteria for decision-making when there is not enough good and reliable data and research. What can we do, especially at the beginning of an outbreak, when the data is constantly changing or limited? What do we implement in order to contain and control the onward transmission? So for these reasons, the PHSM Secretariat has been working on the draft of PHSM Decision Navigator. And we want this tool to include these elements and qualities. We want to make sure that we're able to provide guidance to the decision makers to make risk-based and evidence-informed decisions while they consider feasibility, unintended negative consequences, and evidence on effectiveness. So what we aim to achieve is guidance on how to determine targeted combination of PHSM that should be implemented along with mitigation measures. This refers to social protection policies, programs, and community-based initiatives. And how to integrate enabling functions such as RCCE and epidemic management to better understand the acceptability, the hurdles, the challenges, and impact at the community level. And another element is how to adjust when context change. When do we scale up and down or even phase out public health and social measures? So these are the elements that member states asked the PHSM Secretariat to provide guidance on. We're at the very early stage, still working on the first draft. So this is an invitation to you, to the IOA network, to co-develop this guidance. And that is why I wanted to spend a bit of time today to walk you through the original or the initial structure of this PHSM Decision Navigator. So we want this navigator to help decision makers to navigate through this complex, evolving, simultaneous decision making, so that they have a systematic process to considering various range of considerations. This will be grounded in the best available evidence we have. We have been conducting umbrella reviews, scoping reviews, and synthesizing the available guidelines and guidance related to PHSM. And we are mapping all of the relevant assessment tools and guidance that we have in-house, such as rapid risk assessment, IOA, and tools and such. And this tool will be multi-hazard in the beginning, and it will be followed by modules that focus on diseases, certain settings, or populations. If you have any questions at any point, you can flag, because I don't want it to be a long presentation and just Q&A at the end. So if you have any specific questions along the way, please let me know. Because what I'm about to show you is the decision pathway that we're considering to include in a decision navigator. And I would like you to think about where IOA comes in here. And what kind of analytics and insights that we should be logging here so that we can systematically integrate into the drafting of the decision navigator. So let me walk you through the milestones, decision pathway, and we can discuss. So the initial starting point is the risk assessment. This happens outside of PHSM decision making. This is the first thing we hope that countries would perform in order to best understand hazard, exposure, and context. So we're not just talking about who's affected, where, and how, but also what kind of societal economic contexts are coming into play that affect the epidemiological situations. So risk assessment tools are being developed for member states, and there are various different ways to quickly but also thoroughly understand evolving risks. So we would like to highlight some of the PHSM relevant risk indicators, and that is the gray top left corner. So once you have the risk assessment, what we want to determine is the scale of PHSM response needed. So if, for example, we do not have any vaccines or therapeutics, if this is still at the beginning of the health emergency with the window of opportunity to contain, we would like to see if stringent or higher combination of PHSM can be implemented. That was the lesson learned from COVID-19. Those countries that implemented stringent measures were able to really flatten the curve and be able to control the initial transmission and slow down the transmission. So these are some of the considerations related to the reliability on PHSM. Another thing is health system capacity and also the population immunity. So once you determine whether you would utilize PHSM at the moderate level or advanced level or intense level, the next thing you need to do is to match the potential PHSM to risk and scale that you have identified. So for this one, I will provide what resources and considerations that we are thinking about, but we would like to basically list all of the potential public health and social measures that may be relevant and proportional to the risks that were previously identified. Now, the third step is to fine-tune that list based on feasibility, based on the known unintended negative consequences, and also the combination of these two based on the evidence, but data and research. This fine-tuned list becomes the targeted combination of PHSM. So you might have started at 30 and then fine-tuned to 10, for example. So once you have the combination of targeted measures, we'd like to identify what would be the needed mitigation measures. Do we need to introduce new social protection policies and programs? Do we need to scale and expand on the existing social protection related services to certain population groups? What are the community-based interventions for mitigation of PHSM implementations? So this is when decision makers really think about not only the interventions, but also these mitigation measures to address equity, to address unintended negative consequences. Once you have this PHSM implementation package, then the next step is obviously to develop an implementation plan and monitor these policies. We have developed a separate guidance on monitoring PHSM policies, so this navigator is not going to go in detail. The last piece is, now that you have gone through the decision pathway based on the initial risk assessment, but quickly the situation changes. The risk characteristics changes, context changes, transmissibility, severity might change. So how do you go about scaling up or adjusting the different combination of PHSM? So we'd like to provide guidance on this one. So I hope that this decision pathway is clear. It's a really complex version that I'm showing you here, but what is additional is the last two columns on the right. So this really spells out the key indicators and considerations that we will provide as a menu, as a range of considerations, and provide matrix tables and scales for them to systematically assess various different tools. This will be digitized so that you can click through and be able to reach your unique set of PHSM implementation as a package. So I want to highlight where the community piece really is important in this decision pathway. So first off, the very first step, the risk assessment and also the triggers for adjustment at the very end. We are needing a very granular data on the changes in contextual factors. So it might be the community level epidemiological dynamics that are changing, and that calls for adjustment of PHSM. It might require additional set of PHSM. It might require longer duration, higher intensity. It might require adjustment to the social protection programs. So this community level epidemiological dynamics and data is important. Another thing is the impact, the unintended negative consequences of PHSM implementation. How is the community experiencing some of these public health and social measures that might have impact? For example, hand washing may not be big of a deal, But when children are not able to go to school and miss a school meal, or not able to interact with their peers, or not able to leave the household, when it's not a healthy environment, that has an impact. When a job loss happens, what is the impact at the community level and household level? So we really need this granular community level data on the unintended negative consequences, but also acceptability, understanding, knowledge, and willingness to adopt public health and social measures. During COVID-19, we have seen some of the surveys that were conducted, but it was really difficult to have frequent data points on these changes at the community level. So I really hope that IOA will be able to bring in some insights for these 2 points of the decision pathway. Another point is how communities can be involved in all of these steps of long listing, short listing, identifying the mitigation measures. Now, mitigation measures may be social protection policies at the government national level, but also there are quite a bit of community-led, community-initiated, community-based interventions and programs that have facilitated access to PHSM, but also how to cope with the unintended negative consequences of PHSM. So these are the areas that we'd like to better understand what had worked well, who are the prominent leads, what are the resources available, and we'd like to be able to provide this information to the decision makers. What we have on the very right-hand side are the products, tools, databases, publications that we're developing that supports each of these steps. I will be walking you through some of these in the presentation later, but we have the umbrella reviews, scoping reviews to provide some ideas on effectiveness and unintended negative consequences. And this is at the literature review level, but we would like to have really a context-specific community level tool to monitor and gain some of this insight that influence the decision making. So that is the linkage that I see with IOA. I will be moving to different tools that I mentioned on the right-hand side now. If you have any comments, suggestions, reflections at this point on the decision pathway, it might be a good time to open the floor. I can't see the videos, but if Maria-Emily, if you can help me with any questions or comments that the audience might have, I would appreciate it.
Sure. So for now, there are no questions nor hand raised. So I think maybe you can continue. Oh, yes, there's a hand raised. Nicole, go ahead.
Hi, thanks for this presentation. This is really interesting and very informative. And hi, everybody. This is Nicole Grable. I'm the Senior Technical Advisor at Save the Children for SBC and Community Health. I just, when we get to that point, I would love to discuss some of the resources that we have and tools that we use at the community level for this type of work. But what my question leading into this is what we're looking at right now, this decision pathway and the different steps. At what level is this work being done? Is this at national level or subnational level? Because we essentially do a version of this at community level. So I'm just wondering how, at what level is this process done, and then how does it carry forward? So I'll jump back in when we get to the other discussion about tools and resources as well. But for now, over.
Excellent. Thank you very much for that question. So we have framed the target audience to be wide. So we are talking about national, but also subnational level. We need to have a clear delineation on what it means to have community leaders and community members involved in this decision making steps, but also in collecting relevant data and translating that data. But we are looking at all levels, and also for health and non-health sectors, especially when it comes to mitigation measures, the social protection and community-based interventions to help with economic hardship, food insecurity, social support, violence-related matters. We need to work with various different sectors. So it is, the target audience is quite wide. I hope that answers your question.
You had the thumbs up.
Yes, thank you.
Sorry?
There aren't any more questions. You had a thumbs up
Okay.
from Nicole. Go, you can continue. Thanks.
Great. So I think what I would like to do is to invite you to review and provide comments on the first draft of the Decision Navigator, with some of these key points in mind where community level multidisciplinary information are needed and engagement is needed. I would love for your review. So I will work, coordinate with Marie Emily when the first draft is available to solicit your feedback. And also once this tool is available, we would love to work with you how we can pilot test this and also use it in simulation exercise at the community level, because this will help the national policy development, but also the key point is how do we ensure that PHSM uptake and adherence is maintained? So that's where the community level engagement comes in. So we'd like to work with you on that level. All right, so let me quickly switch the gear and walk you through some of the tools that we have been developing that will be immediately can be used by you and should be able to help your work, area of work, and to also explore what's available out there. So just to list some of them, I'm not going to go into too much detail, but we have published a conceptual framework that defines the different categories of interventions, contextual factors that we're referring to, health and non-health related outcomes, and unintended negative consequences. So I'll provide the links in the chat when I close the presentation. We're also working on research priorities 21-2030. We published the COVID version, but we're now working on medium to long-term research priorities. And this not only includes the topics, disease-related topics, so health emergency-related topics, but also methodology and strategies to strengthen PHSM data, research, and decision-making. So community level and also multidisciplinary integrated insights that inform PHS making is part of this research agenda. So I think that the implementation of this research agenda is something that we should discuss with the IOA network in due course when it's ready. Study protocols, I have a specific slide, so I'm going to skip. Another thing is evidence reviews. We were able to finally publish the systematic review of systematic reviews on PHSM effectiveness and unintended negative consequences. This is believed to be the most comprehensive and up-to-date overview of research available on PHSM. So I will also share the link later on. We will soon have the review of scoping review of social protection policies. Some of you have already received some information on this, but we have the final peer review ongoing at the moment and hope to be able to publish in the second half of the year. All of these reviews will inform the development of the Decision Navigator. And these rest of the tools, I have a specific demonstration. So this one, PHSM Knowledge Hub, we just launched this about 2 months ago. This is the database that you can go right now. I'll share the link. where everything related to PHSM on 23 different diseases from the last 34 years have been harvested, indexed, and collected in this single database. So you do not have to come up with a long string of search terms to be able to identify PHSM. So not only that, it has a very easy, almost like online shopping, easy to navigate through the different types of literature. So I have a video. There's no sound, so I will keep narrating the steps. But this library, is it playing? There you go. Has the bibliographic library of the phase 1, but we also have the AI-assisted systematic review coming. And the research atlas. This will be the AI-powered mapping of research to conceptual framework. So these two components are still under development, but the bibliographic library is live. Once you click the search library, it looks like this. And we have built in the search bar on top. You can obviously put in any set of search strings. We have a huge taxonomy library. So you can use related terminology and you will be able to find relevant research articles. You can also click through by PHSM categories. So if you want personal protection measures and social measures only, then you can simply filter out. You can also choose from the disease list, and that makes it really easy to narrow down your search. Another thing is the setting. So PHSM are implemented across the board or in specific settings. So you're able to select the relevant one, like so. And the abstracts are visible and also able to export into various formats. I think I will click through now. So I will share the link, but this will be the go-to centralized database if you need research-related information. We're going to be adding external guidelines, guidance, and resources, focusing on UN agencies, so that can be also searched here. So for your information. Another thing that we're working on is study protocols. So during emergencies, we learned that the methodology and the study protocols that were used were not really in a harmonized way in terms of how the study designs were set up, the language to refer to certain types of PHSM were really heterogeneous. So in order to increase the quality of research, but also to facilitate comparability and rigor of research, we are developing a series of study protocols, sort of like the unity studies or solidarity trial protocols that you might be familiar with. So it's a set of templates that you can go through. It has various different options that can be considered and adapted to your context. They come with a facilitation guide that specifically focuses on challenges related to methodologies, but also legal, ethical, logistical issues surrounding conducting research studies. During COVID-19, if you recall, some of the RCTs were really difficult to implement. Some of the study designs were not considered appropriate or feasible. So we provide the protocols along with the guidance on how to maneuver these challenges so that we can quickly set up the studies and be able to conduct operational studies to inform decision making. So this applies to the community level as well. The template looks like this. And on the left, you can see the headings or the contents of the protocols. We try to standardize this so that no matter which disease setting or interventions we're looking at, we have a set protocol. And it's designed so that it's flexibly adapted and has a least assumption so that you can harmonize the approaches in terms of study design and be able to be flexible with changing dynamics and situations, and does not require complex data, complex design. So we try to make it pragmatic and feasible in terms of the design, and be able to have early effectiveness study launched during emergency. So as of now, we're working with Marie-Emily on this one, contact tracing. But we have these diseases and combination of interventions that we're working on. Once we're done with the first 8, we plan to expand to another 8 with priority pathogens and interventions. But we hope to have dozens of different protocols that could be made available before the next emergency, or so that these really increase the quality and diversity of research questions that we should be covering during emergencies. I mentioned about the guidance on monitoring PHSM policies. Maybe some of you were involved in tracking PHSM policies. There were Oxford, CoronaNet, various different versions externally, but also WHO regional offices try to have a dashboard and their own monitoring of policies. This was proven really, really difficult because each of them had their own taxonomy, language was different, the grouping was different, the coding was different. So we've been asked to provide standardized, harmonized guidance on how we measure PHSM policies. We are about to publish this very soon. This includes the first, second level categories and high level indicators. You can't see this, but this is what I showed you earlier. We have the policy classification matrix for PHSM. And what this does is, for example, remember on the MOH website or in media, there's an announcement on public health and social measures. And if you really comb through, there's quite a bit of information about which intervention, which geographic scope is covered, for whom, from when to when, how it's enforced, is it just information only or is it mandatory? And this was quite a work for data collectors to systematically and harmoniously harvest. So we're trying to have the standards and categories to convert that into a database. And we are going to be developing a digital tool where anyone, whether you're WHO or university or government, will be able to anonymously or publicly start a dashboard when there is an outbreak, so that you can start data collection at early on. And this policy data is going to be the source of information for effectiveness studies, for decision making, and to be correlated with different insights, such as unintended consequences, impact, behavioral and cultural insights, medical countermeasures, epidemiological situations. So this is just a one cog of the bigger health information system needed for health emergency decision-making, but at least we have PHSM covered with this guidance. So once it's published, and we'll share the link with you, and that's it. There are so many other initiatives, products underway that I can't cover in this presentation, but if you go to this QR code, you'll be able to see the breadth and width of the PHSM initiative that we're working on. So I'll hand back to you, Marie-Emily.
Thank you so much, Ryoko. This presentation is super rich and we're almost at time, and I have hundreds of questions and I should have taken the opportunity before. Colleagues, if you have any questions, please do raise your hands and shoot out. We have 7 minutes left. Until I see some hands up, I might come back to the decision pathway and potential collaborations with the IOA network. You mentioned, I think what you suggested is collaboration around the development process, but also populating the decision framework, and then eventually maybe supporting with the rollout, piloting and rollout of the decision framework. And I think that would definitely be super interesting for the IOA network to be involved with.
I'm sorry. I don't have cash. I just
Hi, Emily.
wanted to say hi.
Sorry.
I'm so sorry.
Up there. I was wondering about how resources in countries are mapped, because it's one thing to say this is what you should be doing, but then countries, and it's part of the context certainly, in terms of capacity of the healthcare workers, community health workers, communities, what capacities exist and what tools exist, the practical tools, the money, etc. So how do you include that? And then I'm just going to move to the different tools you showed. When we did the systematic literature review for contact tracing, we definitely saw there was a huge bias of dissemination of information and research, geographical bias, mostly coming from rich countries, but also obviously a lot from COVID and less from other settings, also because other diseases are in different settings. So I see how the different protocols could address that, mitigate that issue and those risks of only having one vision. But are you also planning for some support to roll out those protocols, and what kind of support? Relying maybe on partners also, academia in those different countries, etc. Now I'll shut up and let you answer.
Great, thank you very much. So the first question was on how we realistically roll it out and what are the resources available. So public health and social measures, if you think about maybe the Ministry of Health that you have been working with, or the task forces in charge of COVID-19, was there anybody in charge of PHSM? Was there a dedicated team for PHSM? The answer is probably no. It was mostly the health emergencies crew, Ministry of Health crews that were repurposed to look at PHSM on an ad hoc basis. But once the emergency finished, or that their incident management role ended, then they went back to their own job. And it has not been spelled out in national or sub-national health emergency response preparedness plans. So what we're trying to do is to really integrate PHSM pillar into the capacity building programs, into the national plans for preparedness, readiness, and response, so that we have the systematic dedicated resources, personnel, and even the tools and thinking around PHSM. So that's where we're starting through, for example, WHO benchmark, through PRET, and eventually working with the Ministry of Health in terms of leadership and governance for PHSM. So that's in the horizon. We've been focusing on research, but the capacity building and rollout would be the next focus. And the second question was on the study protocols, how we roll it out. So we are establishing a WHO collaborating center specifically to have the continuous development and adaptation of these protocols, but also to be able to provide guidance to those who are actually going to be using, adapting, rolling out the guidance, so that we sort of have the collaborating center, but also the research network to be able to provide the methodological support in the future. So that's the kind of framework that we're trying to establish.
Thanks, Ryoko. Thank you so much. Sarah was posting that she's leaving. And I posted some of the links that, as you were speaking, I posted what I found on WHO website. But we can also have a summary email that we send to everyone by the after this call, so that they all have the presentation plus this. So just to come back to IOA, and we only have a minute and a half left. So IOA is not only, well, it's obviously centered on communities, but also, as you know, taking into consideration the full context. So I definitely do see how there could be some synergies working together with PHSM. There's also a whole part of the IOA approach that looks at what the recommendations that have been co-developed with the different stakeholders, including the communities, how are they being implemented, and and measuring them with indicators, etc. But those activities would probably be PHSMs, well, likely would fall under the PHSM terminology. And so, all of those methodologies that are being developed to follow those, to monitor those, the tools that are being developed to support monitoring of the PHSMs. I think here also that we could see synergies and working together so that we don't develop several different tools, but we also really work together in terms, and with countries, so that in communities, so that they don't have several people talking to them and presenting several different tools that they should use, but being kind of aligned. And I think that would be really great. I'm sure. I'm a little bit disappointed that we didn't have more people. Today is the start of the summer. I'm sure this session is really of interest to many people. So if it's fine with you that we share your presentation with the whole group. Yeah, we'll do that, and then we'll send to everyone the links that Ryoko shared and mentioned. And also, if you have any questions for Ryoko, you can, reach us, and we'll be relaying those questions directly to the PHSM team. So thank you very much again for being here. Thank you everyone for connecting. And we'll be posting this this session on our YouTube channel. And I think the next session, and I apologize, I am not Ruby. I don't remember what the theme is. Maybe if Emily does, I'm not sure. But anyway, there's a next session end of July also, and I hope you'll all be there. Take care. Thanks. Bye-bye.
Thank you.